Good afternoon and welcome to today's joint Samantha R webinar with the Division of Mental Health, Developmental Disabilities, and Substance Use Services and Disability Rights, North Carolina. Before we get started, here are a few reminders about the webinar. Please make sure you're using a computer or a smartphone connected to the internet and the audio function is on and the volume is turned up. Please be sure your microphone is muted for the duration of the call unless you're speaking or asking questions. To ask questions, use the Q&A feature on your control panel, and we will answer as many questions as time allows toward the end of the presentation. American Sign Language interpreters and closed captioning options are available for today's event. The American Sign Language interpreters for today are Danette Steelman Bridges and Susan King Lanner. For closed captioning options, select the closed caption feature located on your dashboard. To adjust your video layout and screen view, select the View feature located in the top right-hand corner of your screen and choose the view that works best for you. Today, we will share updates on the Samantha R consent order from the Disability Rights, North Carolina, and the Division of Mental Health, Developmental Disabilities, and Substance Use Services. There will also be time for questions after the presentation. At this time, I'd like to turn it over to Kelly Crosby, Director for the Division of Mental Health, Developmental Disabilities, and Substance Use Services.
Hello, everyone. This is Kelly Crosby, and I'm the Director of the Division of Mental Health, Developmental Disabilities, and Substance Use Services. For those of you that don't know me, there's a little bit of information there on the slide. I have been the Division Director here since December of 2022. I'm a licensed clinical social worker. I've been at the department for quite a few years, about 13 and a half. And I've been in this field for a very long time, and I've worked in mental health, substance use, and I've worked supporting people with intellectual and developmental disabilities, and I'm a person with lived experience. So I'm so glad that you could join us today. This is an incredibly important topic, and we're going to do our very best to walk you through the history of the Samantha R legal issues, where we are currently in the consent order. We're going to walk you through the consent order about the things that we're going to be doing. And we are going to have lots of time at the end for questions and feedback, and we look forward to that. But we thank you for joining us here for this really important conversation. We're very committed here in North Carolina to making sure that our public system keeps on improving, and we do better and better to meet the needs of individuals and their families, individuals with intellectual and developmental disabilities. And so some of the actions that we talk about today are ways to make sure that individuals with intellectual and developmental disabilities are living their best lives. They're living, working, playing where they want to in the community. And that's what we're committed to. So I'm going to turn things over first to Corey Dunn. She's the Director of Public Policy at Disability Rights, North Carolina. Corey, over to you.
Thank you so much, Kelly. Good afternoon, everyone. As Kelly said, I'm Corey Dunn. I'm the Director of Public Policy at Disability Rights North Carolina. For those of you who don't know, Disability Rights North Carolina is our state's protection and advocacy agency. There's a P&A in every state and territory of the U.S. and Disability Rights North Carolina has been North Carolina's protection and advocacy agency since 2007. I've been with the agency since April of 2011. I'm an attorney. I've formerly worked as a direct support professional in multiple settings and was really raised up around IDD services. I'm kind of a second generation IDD service provider. And I'm also a person with lived experience, and I'm an attorney. And I do this work because systemic change is what helps me get up in the morning and feel excited about my job and about our community. So I'm so excited to be here to talk with y'all today, and there will be lots of time for questions. So I am eager to hear from you all as we move forward. So I'll just take a little stab at telling you how we got here, and also what the consent order is. So let's start with the fact that Disability Rights North Carolina filed this case in May of 2017. That was 7 years ago. And of course, when we filed the case, that was after years of work in the IDD system and efforts to make more sense and frankly, honor the promises of Olmstead, which in 1999 clarified that people with disabilities have the right to receive services in the least restrictive setting that's appropriate to their needs. And that means you shouldn't have to be in an institutional setting to get your needs met if you don't want to be. So in February 2023, almost 3 years into the case, the court made a decision that the state was in violation of the integration mandate. That's what we usually refer to as the Olmstead requirement. That's the least restrictive environment requirement of the ADA. And then 2 years later, DHHS presented an Olmstead plan. The court determined that the Olmstead plan would not suffice to solve the violation. The court entered a remedy order in early November 2022. It imposed benchmarks for transitioning people with IDD to community settings from institutional settings if they chose. And it provided for the elimination of the innovations waiver waitlist in a period of 10 years. It directed the party to make recommendations regarding access to direct support professionals, DSPs. You'll see DSPs throughout this conversation. We're talking about the folks who actually do the work. So who are the backbone of our workforce in IDD services. In November of 2022, a few weeks after that order, DHHS appealed and challenged both the original February 2020 liability finding and the November 2022 remedy order. The parties mediated the case, and the proposed consent order is the result of that mediation and negotiation. So let's talk about what that consent order actually says and does. The IDD community has noted since we released the proposed consent order on April 10th that the consent order does not provide everything that DRNC sought in the litigation, nor everything that the court ordered in November of 2022. The consent order is an interim measure that moves the parties closer to a resolution of the litigation. At the end of the 2-year period governed by the consent order, the state may seek to end the court's involvement. So they could ask the court to decide that the state is in compliance. And likewise, the plaintiffs, that's us, may seek additional orders if we believe that those are necessary to address continued unmet needs. Since the remedy order in November 2022, the state of the system has continued to change. So things didn't just freeze at that moment. We got the beginnings of 1915I, and we've got lots of other changes. We are headed toward tailored plans. The consent order provides for in-reach, transition support, diversion, that is having people go where they want to go rather than being funneled into institutional settings, and other critical measures, including data and compliance oversight. And importantly, the legal requirement here, the requirement of Olmstead, of the ADA, that's not new. This is just a new plan to implement that. And so I urge you to view it from that framework of this is all about how do we get to the promise of Olmstead, and how do we do it in a way that really engages all of the parts of our system that are so essential. There's not a single part of our system, from legal advocates to the state, to providers, to MCOs, to people with IDD and families, to the DSPs who are yet to be. We can't do this without a single piece of that system. And so we're really asking you here to join us in this work over the next couple of years, or recommit to the work if you aren't new to it, and to help us design what is next. And I'll turn it over to Kelly to give you the framework from DHHS's perspective.
Thank you very much, Corey. Hey, everyone. On the next slide, you are going to see kind of a visual representation of the course of the Samantha R. litigation. I'm not going to go through this. Corey is the attorney, not me, but it is a visual representation of what Corey walked through. The slides are available, so feel free to look at that. And please note that in addition to Corey, we have other attorneys on the call today who can answer questions for you. What I really want to walk people through is the next slide. So the next slide talks about the areas of agreement in the settlement order. So these are the things we're going to work on. And I really want people to understand what these are because these are the really critical actions that we want to take starting now. Some of these have already started through the next 2 years and beyond. So this will be an incredibly important time for us to continue good work, start new good work, and collect a lot of data so we have a little bit better idea of what some of our needs are, some of our gaps are, where we need process improvement, where we need additional services and supports, additional workforce, et cetera. So this will be a good opportunity for us in the next 2 years while we're working through these activities. So I'm going to go through them one by one. The first is around InReach. So currently the LME MCOs do InReach. And what's InReach? InReach is where someone, a knowledgeable person from the LME MCO in this case, will talk to an individual who's in an ICF, for example, and talk with them about the options and other available places to live in the community and help them know the choices that they have, help their families understand the choices that they have. As Corey described really well yesterday, it's not necessarily a one-time conversation by any stretch, but it is a process by which we want to make sure that people understand, maybe for the first time, maybe for the 5th time, other opportunities they have to live in different integrated settings within the community if they so choose, and the type of supports and transitions that would occur to get them there. So as I mentioned, LME MCOs are already doing this. It's important that you're going to hear me talk a lot about how a lot of our work will happen through LME MCOs or through LME MCOs and providers or through LME MCOs and providers and consumers or families. Because much of what we do is a partnership with folks locally. And of course, we have a contract with our partners, the LME MCOs. So as I mentioned, we will, under this order, be doing additional and more InReach. So through that InReach, we'll have a better sense and be able to identify or maybe educate some people for the first time, or like I said, the 5th time, about the opportunities they have to live in alternative settings, integrated settings within the community, and the type of services and supports they could get to effectuate that kind of transition. Also, around the 1915I option, remember that's a term we're working on making sure that we clarify for everyone. 1915I is just a federal authority that allows Medicaid to pay for home and community-based services. But it's a small list of home and community-based services that are now a Medicaid entitlement program. Those rolled out last year. Some people know about them, some don't. But under this provision, we have agreed to make sure at the state level, the process by which we determine people are eligible for 1959, because it's a Medicaid program, so you've got to be eligible. We're going to make sure that is done as efficiently and quickly as possible. So that's what we're committing to in this order, that we'll make sure when folks are requesting 1959 option services, we're efficient and quick as possible to make sure those assessments and eligibility determination gets completed. In addition to that, to really make sure this provision is effective, we'll be doing a lot just to make sure that everyone is much more aware of 1959 option services, things like community living supports, respite, supported employment. There are also services for people with traumatic brain injury and serious mental illness, but I'm focusing on the IDD services. So, and transition support is another 1915I Medicaid service. So we'll be making sure that we have some accessible communication, explaining what these new services are, how people can tap into them, and we'll be doing additional work around making sure we have more providers and the workforce necessary to provide more people services. There will be active outreach to people on the waiting list, so they're made aware of these services and how they can get them. 1915I is a real opportunity for people who are waiting for Innovations waiver slots to get home and community-based services. These 1915I option services are a small subset of the Innovations waiver services. I may be saying something that you know already, or I may be saying something that you didn't realize. And we want to make sure that people do realize this is a wonderful medical aid entitlement. People who are waiting don't have to keep waiting. We can start to get people assessed, determined eligible, and into services, even while they're on the Innovations waiting list. Okay. So the third thing, LME MCO standards. So I'm going to go back to what I said a minute ago. Remember, this agreement is between DHHS, so the department, and DRNC, but we do much of our work through contracts with LME MCOs. So one of the things we've agreed to is that we'll set standards in those contracts with LME MCOs to make sure that people who are authorized for services are getting more of those services. That's not an easy one. It's quite complicated, but we want to make sure that if someone has an ISP, an individual support plan, right, a person-centered plan that lists their service needs for the year, their plan for the year, their goals for the year, that we're all doing our very best to make sure people are getting as many of those services they can. Some people can choose not to get services sometimes. Sometimes people go on vacation or unfortunately are hospitalized for reasons. But there are times too when folks aren't getting all of their services because they're having trouble with staffing or workforce. And so we want to make sure that we are setting a target. We are asking ourselves to improve year over year to get people into more of their authorized services. So the services they were expecting, the services that they created an annual plan for, we want people to get those services. That one's rough, but we're setting targets, and we will be helping and working with LMEs and providers to try and meet those targets. Part of how we'll meet those targets are some of our workforce strategies. So as part of this consent order, we've also agreed to both develop and enact a direct support professional workforce strategy. We already have a draft of this. Many of you are actually quite familiar with the projects we want to try under this strategy because we've been talking about these strategies with the community in our direct support professional advisory group. So the workforce strategy will contain everything from including to advocate for higher wages, but it will include projects like creating a pipeline with community colleges. We've got an exciting community college pilot that we're about to begin. Well, they'll do in-reach in high schools. They'll have a certification program. They'll help people get apprenticeships, paid apprenticeships. They will get wraparound supports while they are a student in the program. So that's one exciting thing we'll be piloting, but we'll be piloting other things like additional employment supports, incentive bonuses for longevity, career paths where people can get wage increases the longer that they stay in employment, but also supports for providers too. Providers put a lot of effort into recruiting and training direct support professionals, as do families. So we want to make sure that we're providing adequate supports, both for helping that recruitment and retention, and in some cases, family matching to direct support professionals. We have some ideas there. So you'll see that strategy. We'll get lots of feedback on the strategy, but we're starting now to implement some of those projects. And we'll be looking at those projects to see if they make a difference. The goal is to make sure that everyone in North Carolina and beyond knows that being a direct support professional is a wonderful career, very valuable career. There's a clear pathway for the career, and there are incentives for maintaining that as a career. So that's the direct support professional. The last thing that we've agreed to in the consent order is data and reporting, and that's incredibly important. I mentioned earlier that we're going to use this time to collect a lot of data, to be transparent. We're excited about that. And then to use the data for additional planning beyond these years, right? So we are going to, as we're doing more 1915I evaluations, right? As folks are getting more assessments and creating more plans and beginning to use iOption services, we'll get a much better sense of the needs of folks and how that benefit is actually working, how the services are meeting the needs of people on the waiting list. We'll be trying out a direct support professional strategy. So we'll be able to see, is that helping folks or is that getting more folks into the profession, maintaining the profession? Are people able to get more of their authorized services because we have more direct support professionals? So we're going to find out a lot during this process. We'll find out a lot from InReach. We'll find out, hey, we need to do a lot more education to families and consumers around housing availability. Hey, we are finding that there's a real demand for certain types of housing, independent apartments, adult family living. People didn't even know they existed or what they are, or even there's more requests for more person-centered activities in ICFs, because people want to live there, but they want more community opportunities while they live in ICFs, for example. So we know that we'll find out a lot of data in the InReach process, both people that want to move, but also other support services and housing options that they want. And we intend to use this data as we move forward. So we're committed to doing all of these things, sharing the data that we're collecting, working towards targets where we're making a difference, where we're transitioning more people, getting more people into authorized services, getting more long-term direct support professionals in the field, getting more folks into iOption services. We're committed to knowing more about it, collecting that data, and achieving some targets. On the next slide, and this is where I'll wrap up and we'll have time for questions. Hopefully folks saw the Samantha R press release. That was a joint press release that we released, we and DRNC released. So you can go to that QR code to see the press release. And also I'd like to point out the QR code for Inclusion Connects. So Inclusion Connects is our DMH-DDSUS initiative. It's got 3 component parts, which is to get individuals with IDD, more of folks into services. So people on the waiting list into services, people on innovations getting more services, right? So we want to make sure people are getting more services like tailored care management, like community living supports. We also want to make sure that we are laser focused on direct support professionals, the things we can do in our department, but also the things we can do in partnership with others in the state. And lastly, we want to do more to make sure that we have a solid housing plan. So as you can see, Inclusion Connects aligns really well with Samantha R. We'll make sure that we are achieving everything that we agreed to in the Samantha R consent order and more. But if you want to know more about that, the QR code there will take you to the Inclusion Connects page. Now, that's the end. And I am going to ask Corey to join me again. And we have others, as I mentioned on the call. And we are super happy to take questions and comments. And Katie's joining us too. Katie's going to facilitate questions.
Hey everyone, good afternoon. Just want to take a moment to draw your attention to the Q&A feature in Zoom. We did design this webinar with it in mind for folks to have ample amount of time to answer questions. So please don't hesitate to add any questions there, and we will do our best to answer as many as time allows for those that pertain to the Samantha R consent order. We did first receive a question about the innovations waiver. So I'd love to turn it over to Corey and Kelly to speak a little bit more about that.
Thanks, Katie. And thanks, Ray, for the question. The question is that without the former remedy order provision that included clearing the wait list, what do we actually think our chances are of meeting the needs of children and adults with significant intellectual and developmental disabilities in the community? And absolutely, this is central to our concerns here, right? We think it's really important at this point that we shift our attention to demanding results of really concrete, specific items. And those include the DSP development pipeline, Those include the actual measurement of the percentage of services approved that are eventually billed, right? Because you can be approved for, let's say, 10 hours of services, but if you can only staff 5, that doesn't help you with the other 5 hours, right? So it's essential that we be developing the DSP pipeline. Part of that is going to be paying them what it costs to get people to do this work, right? Things cost money, and no one here has any illusions about that. So we will need to work to develop appropriate rates. That will mean both legislative advocacy in the short term to address the shortfall, and also improving our systems for ongoing, routinely setting rates in a way that makes sense for our community, because what we have right now is clearly not enough. We need for the IDD community, and by that I mean all of us. I don't mean just people with IDD or just family members or just legal advocates or just providers. We need the IDD community to be heard and to be really clear that we insist that we be prioritized. This is a non-joint statement. This is DRNC alone, not DHHS, saying there's an IDD advocacy day on Tuesday, and can you imagine what would happen if 18,000 people waiting for services and their families and their friends called and texted and emailed that day and showed up in force and continued over the next 2 years and beyond to demand that their elected officials prioritize our community's needs. We know they can clear wait lists. They've done it for private school funding. So I would suggest that they are capable of doing this, and I have every faith in them that they are able to. It's going to be up to us to demand that they do it.
Yeah, I just want to add a little bit. To Ray's comments, and Ray, thank you for your ongoing advocacy. You're such an inspiration. Thank you. I'm trying to figure out a way to say this. I'm a plain speaker, so I'm not always so articulate, but the things that we want to do to support people with IDD in our community are the things that we know we want to do because they're the right things, and they're our goals and they're our values. So I completely understand that folks may feel like, wow, there's no legislation that's requiring us to eliminate the wait list. That doesn't mean we're not going to try. Doesn't mean that at all. We successfully got the 1915 I-Option service, which is a big deal. We just need to fix processes, get more workers, and educate folks about the process so people can start getting services now, yesterday. We need to keep advocating for slots, and you're not advocating alone. We are there too. We will advocate for slots. We will advocate for direct support for professional wage increases. These things are important to us. So I understand that the comfort that a lawsuit and a requirement can bring completely. I'm telling you that everything in this consent order are things we incredibly willingly do, are excited to do, and we're excited to do more. So we will continue to advocate for slots. We'll continue to do better and better at getting folks into 1915 I-Option services, state-funded services, and we will continue to advocate for a really strong direct support professional workforce. There was a question too, and I think it's important that we talk about the money for these things. So, Katie, if you don't mind me saying that, because this kind of came up in a similar question. Since the order is between the department and DRNC, what we aren't able to do is commit the General Assembly to additional funding or additional slots. Can't do that. But I hope folks saw that in the governor's budget, and talk about how the governor's budget works, he asked for more slots this year. and increasing number of slots over the next 8 to 10 years so we could eliminate the wait list. Those are our values, those are our goals. And he also asked for both direct support professional wage increases and also additional money for direct support professional workforce initiatives to try to get more folks invested in and interested in it. So this is a value for us. We hope the General Assembly agrees with that. We know they have a lot of priorities. We know your advocacy helps. So yes, we know that in order to eliminate the wait list, we'll need more slots, and that's more budget, but we can't commit to that. We do also know that in order for LMEs to be effective, right, for LMEs to have staff who are well-trained, spend time doing in-reach, right, spend time educating folks around 1959 option services, they may need more money in their capitation. Totally true. And that's part of their typical capitation process between them and Medicaid, right? So having a strong Medicaid program, having a strongly funded, well-funded Medicaid program is incredibly important for us, right? So you'll see that as the governor's priority. We hope, here's the thing, we hope, and we've been very open about this, 1959 is a Medicaid entitlement now. If we can get more direct support professionals and get more people into services, it will increase costs to Medicaid. We knew that going in, right, when we got the entitlement benefit. So again, it's really important that we have Medicaid financing and the Medicaid program continues to be funded really, really well. So, yes, this hopefully, if we do things right, this will cost more money because we'll get more slots, but also we'll be getting more people into Medicaid services or state-funded services. And that's why it's important that we maintain a really good, strong, well-funded Medicaid program.
And that's also why Medicaid expansion was so essential here, because there are many folks who, but for the income cap, would have been Medicaid eligible without a waiver. And so there are going to be many folks who are already on the wait list, but who are not currently enrolled in Medicaid, who we believe have now become eligible. And we want to make sure that everyone who is eligible is enrolled.
Thank you all. That's really important information being shared. We received another question that's asking us, is there a best place to provide, is there anything in place to provide more state-supported services for people without Medicaid? Kelly, would you like to take that one?
Yeah, I have so many thoughts. I'll say what I can say out loud. We have not had an increase in state dollars in a long time. We haven't. We advocated very hard not to have them cut this year when we had Medicaid expansion, right? Because we think the need will be greater than ever for state-funded services. We're grateful for Medicaid, but the reality is state dollars cover lots of things Medicaid can never cover, and there's still lots of uninsured folks, right? So there has not been an increase, but here's what we're optimistic about, right? We are optimistic that as more people get especially covered mental health, substance use, these I-option services on Medicaid, that frees up more dollars. So we hope it does free up additional state dollars that we can put into things like home and community-based services. So we are hopeful. I'll just be honest. There are legislators listening. We're really hopeful that as we collect this data, we'll just be better informed and better able to advocate for, hey, great, we've got this many people on that waiting list getting I-option services, and that's great. But now we know that we've got 3,000 people without Medicaid, and they really need community living supports too. And this is how much it's going to cost for these 3,000 people. So we hope we get better at asking for the things that we need, because there's still lots of people that really rely on those state dollars. So as of now, there's not been any increases, but there's not been any cuts. And I think it's very important for us to be transparent about what those dollars go to and be smart about sharing that, and then sharing what we think or where we think, especially for folks on the wait list, we might need additional dollars.
Corey, did you want to add anything to that?
I think that was great.
Wonderful. All right. We're going to look at our next question here. It was received, and it's talking about the DHHS data related to additional dashboards and the frequency at which they're updated. So I thought, Kelly, if you wanted to speak to that, let people know about the data that we do collect, I thought that'd be great.
Yes, y'all, we collect lots and lots of data, and I'll be honest with you, and if maybe Badia, because you're so good at this, maybe you could put the report site in the chat so people could see it. We collect a lot of data, but we only publish a portion of it right now. So that's one of the things we want to get better at. But one of the things that does get updated every single month, it's called the LME MCO dashboard. And I call your attention to it because it's a slim list of, I think, 5 metrics. One of those metrics is actually the percentage of people on the innovations waitlist who are getting either a Medicaid or state funded service. So that is a priority for us, and you're able to see by LME MCO, just that, the percentage of people on the wait list who are getting services. But we collect a lot of other data, and we are working to make that more visible and more digestible for people. We produce a lot of data, and it's fascinating. Gets sent to me, gets sent to LMEs, doesn't always get posted, but it's data that you want to know about. One of the things we're working on, besides all this data that we will report, we're actually working on, we've been for a couple of months, cleaning up the information we do have on the wait list right now. And so we will be creating dashboards to show people more about the wait list, because now you can see the number of people by county that are on wait lists. But we know a little bit more than that. We still need to know a lot more, don't get me wrong. But the ages of people, right? What we do know about the diagnoses or their identified service needs, how long they've been on the wait list, right? Other demographic data, right? Gender, ethnicity. So we're pulling together all the data that we have. We're working with the LMEs. This is not an EG project. So we're not only going to share the data we do have about people on the wait list, because that's really critical for transparency, but also for planning purposes, right? We're also going to be working on a better way to collect and refresh the data. Some of the data is way old. It's got to be standard. It's got to be fresh. And the best way to get fresh data is to do outreach to folks on the waiting list, to tell them about iOption services and get them in them, right? So we're really excited about, let's refresh, clean up the data, and use that as an opportunity for outreach and engagement. Now, the data, and this is where it's too new for me to say, but I have mentioned, like, we're going to be creating data to report for this consent order, right? We want to publish that data too. How are we doing within reach? How are we doing? Like we've already talked about, like we've got 17,500 people on the wait list. Can we also start creating a ticker of like every month, how many new people are getting iOption services, right? There's so much that we need to shine a light on. And I'm optimistic that we'll have things to celebrate too, right? As we get better at understanding what needs are and start filling those needs, we'll have things to celebrate. But we're super committed to sharing some data that we already have a little bit better. But this gives us, I'm excited for when we can share that waitlist data, and I'm excited to share the data we'll be collecting for this initiative, or for this consent order, excuse me.
Corey, did you want to add?
I think it's important. I love the data. I do. But the data, it serves a purpose, right? It's not just to know, it's to inform. So we can really paint a picture of what the need is and then design the path to get there, right? So I just want us to remember that data in and of itself, though it's fascinating, is not, that's not the actual end result. And that's really a lot of what this 2-year plan is how do we learn continuously from the data to improve the function of the system. And for too long, we have tolerated, I think, mismatched data from MCO to MCO. We have dealt with sort of, frankly, surprising and embarrassing gaps in our understanding of the community of people we're supposed to be serving. When I started this work, I remember that people couldn't even come up with a ballpark of how many people had TBI. Just nothing. It was just an absolute blank. So the data is incredibly important, but it's important because it informs our investments. And to someone's point in the questions, I'm sorry, I didn't catch who it was, but this is an investment in our communities, because this is not just about services. For us, this is about, you know, the promise of Olmsted, the dignity guaranteed to people with disabilities under the Americans with Disabilities Act and under state law, and our ability to choose our community and what our lives look like, just to have some basic control over our lives, like just that modicum of control that we're all looking for, right? And so that's critical, but there are also all these really amazing collateral effects. Like imagine if all the family caregivers who are buried under the weight of paperwork and fretting over DSP availability and scheduling and you know, planning. Imagine if all of those people had that space in their brains and their calendars freed up to do whatever it is that they want to be doing. You know, can you imagine the human potential that we are spending on this kind of frantic day-to-day of making sure that everyone's safe and okay? If that got freed up a little and we could take a breath and people with disabilities could engage in activities that they choose, imagine that, and their loved ones could breathe a sigh of relief about the stability of the system. Like all of that could have these incredible ripple effects. And I think we have to give ourselves permission and actually like do the work of imagining what that would look like, because so many of us have lived in a scarcity, fear-based decision-making model for a long time. And I know it's well-founded. I'm not saying that's an irrational decision. People are fearful for a reason, but in order for us to transform the system and to move it forward, we have to insist that we can imagine something better for the people we love and for ourselves. It can't be that we will continue to, you know, scratch out survival. We need to insist that we are essential parts of our communities and we're not optional.
Thank you both for that. There are several questions that are coming through in relation to 1915I, particularly about the impact of 1915I and staffing shortage or service shortages that people are experiencing in the community. So I'd love if Kelly, if you're able to speak a little bit more about 1959.
Yeah, and I see themes when I look. I see themes in the questions around the availability of 1915I option services, processes related to 1915I option services, processes related to care management, shortages of care management, and then also processes related to the innovations waiver. And I bring them all up because they're all intrinsically linked, right? For folks who don't know, right, everybody has tailored care management available to them if they have Medicaid. Not a lot of people are using it, right? And so part of what we want to understand is why folks aren't using it, right? Okay, and I'm sure there's myriad reasons, and there has to be ways to address all those myriad reasons, right? Okay, number one, tailored care management is important because one of the things tailored care management does is it helps a person get an assessment and submit a request for 1915I option services. So that's really important. So even that notion of I should find out who my care manager is and get a care plan. And they can help me not only get 1915I, but other things. Maybe even help me get on the wait list because I don't even know what that is. I have families still tell me today, like, I don't know what that is, right? And that's not the only thing. There are state funded services and there are other things available in communities for folks, right? Okay. So have to have people understand tailored care management, make sure it's working effectively. Care managers and families need to understand how care management helps you get 1915 option services, right? What that process looks like. And I hear from care managers every day, some who feel like they understand it, but don't like it. Some that have no idea how it works, right? There's all kinds of process issues that need to work better, right? It is new. So I'm not picking on anybody. This is new. It's really new. We've never had a benefit like this before, right? And there's a lot of very fussy federal rules. And I want to live in Corey's world where we jettison all that stuff. I really do. it's easy for me to say, because I'm over at DMH CDSUS, I don't have all those federal rules, but I respect the fact that our Medicaid colleagues have so many rules, right? But we still have to figure out how to translate those rules into processes that make sense for care managers and for families. We have to make it easier and accessible and have people understand it, right? Same thing about innovations too, right? So we need care management to get people assessments and to get those IOption and other services. Families need to know about innovations. They need to know what it is. They need to know what a wait list is. They need communication while they're on the wait list. They need to be offered additional services or other services while they're on the wait list, right? There's a lot of things that we want to happen. That's not saying good work isn't happening. Please don't hear me saying that, right? I tend to speak in absolutes, like this is the perfect. There's lots of pockets of good happening. Care management that's happening. People are getting IOption services. People are not only on that wait list, but they are getting services while they're waiting for innovation services, right? Okay. We just have to make sure that it's working like that everywhere, right? People know how to get care management. They know what a wait list is. They know how to get on it. And they're not waiting for 10 years. They're not. They're getting an assessment. They're getting care management and they're getting available services even while they're waiting, okay? So that's what we have to do. And there's a lot of process fixes in there, communication, accessible communication, education of the community, standardization of processes. So people are asking, the bottom line is people are asking, is this going to change how we get on innovations? Is this going to change the assessment process for 1959? I can't even find care management. So I'm responding to a lot of those questions in the chat, right? I'm just saying, I'm not saying, whoo, everything, all the processes are going to change. They might. I'm saying we're going to look at it. We're going to look at the processes to make sure they make sense, to make sure people understand them, they know how to navigate them, and that it's consistent, no matter what LME MCO you work with, no matter what provider you work with. And how can we help? We're here to help, right? When we impose all these rules and regulations, it's our responsibility to help providers, LMEs, and the community understand and make it as simple as possible.
Thank you, Kelly. That's really important. I think it leads to a next great question that was asked of how can we address the shortage in day supports, particularly where there's not many to offer in rural counties. Corey?
This is one of the places where I think 1915I is really critical, because 1915I offers for folks who are not on the waiver is going to be the one of the biggest sources of support for supported employment and for community living support. Those are collectively, those can make up a pretty robust day supports, right? So we used to think of day supports as primarily congregate facility-based care. And that's especially hard to come by in rural areas because everybody's got to travel from somewhere to get there, right? But one of the things that's so great about the services available under supported employment and CLS, community living support in particular, is that they can be really flexible and they can be really elastic and can support someone as their needs change over time. And so those services collectively are an important new resource for our community. And we're going to need to learn to use them in a way that we just haven't had access to it for the thousands and thousands of people who are waiting for services. This is the first opportunity we've had to really imagine what that might look like. And we are not starting that imagining with facility-based services. And so that's, I think, an important shift. If you've been in this world for a long time, you might be looking for the place. Where is the place we go? But this is not about a place. This is about the people. And so I encourage you to think of 1915I that way. And also, you know, waiver supports, of course, are an important set of tools available to us.
Thank you, Corey. Really appreciate that information. All right, we have a question and a comment that came through about EOR. So I think it's important we raise this up. I know Kelly wanted to talk a little bit about this. Particularly what was asked was, can we make EOR simpler as a way to improve equity in services? Kelly, I'll turn it over to you.
Yeah, employer of record. For those of you that don't know what employer of record, it's one of the two ways we have in North Carolina. So individuals can direct their innovations waiver services more, right? And so there's some really good parts about employer of record in terms of hiring your own staff and managing your own staff, and that's great. But I understand that some of the processes and associated with employer of record can be really challenging for people. Kind of above employer of record, that notion of like self-directed care is really important. And 10 years ago, we kind of put a stake in the ground and we said, we want people with intellectual and developmental disabilities to really not only like choose their own plan, but hire their own staff and really direct the course of their lives. And we really want that, right? That's a value. But we don't always see the uptake, right, in self-directed services like we want to. So we know there's a lot of lessons learned in the past years about how it's working or not working. And I think that's another example of we should commit to more self-directed services. And that means making employer of record a really good process that works for a lot of people. A lot of families aren't maybe necessarily employer of record, but they're doing a lot of employer of record type things, right? They're often recruiting their own staff and managing their own staff in partnership with organizations. We have some individuals, because that's optimally what we want, right? Not family members, but individuals who are getting waiver services to be directing their own services. So employer of record is really important. Self-direction, so you're really directing your services and your staff who are supporting you with your services. It's really, really important. And that's one of the areas we flagged. That and supported living. These are really good options and opportunities for people to have increasing levels of self-direction and independence in their services, in their housing, in their communities. But we've gotten some feedback around things that could be improved to make those programs less cumbersome, less administratively burdensome, and be more attractive to people to use them. So hear me say, self-direction is a priority. And for it to be a priority, we know we need to smooth out some of the processes to make it more a better opportunity for individuals and their families.
Corey, did you want to add anything to that at this time? Okay, and the next one we're going to look at is information about dual diagnoses. We had a question come through about services for folks who have an intellectual developmental disability and mental health needs. So how do we work towards helping dually diagnosed individuals that need that increased behavioral help? So Corey, I'd love to turn that to you.
Thank you so much, Katie. Sorry, there are a lot of words flying across my screen. I was trying to find the actual question and wasn't successful. So if I miss a part of it, please redirect me. But the crux of it was, I think, people have dual diagnoses. People have more than one need. People don't like just pick one cookie off of the disability table. Like we get a whole smorgasbord sometimes. And so for folks who have IDD and any other disability related needs, whether that's traumatic brain injury, mental health needs, substance use disorder, and if that's not part of your life, please know it is a part of a lot of other people's lives, right? If that's not the lens through which you view IDD services, please know that the people we most often see falling through the cracks at DRNC are the ones who don't fit neatly into a diagnosis category. They are too something or not something enough for whatever provider is out there. And it is the responsibility of the managed care organizations to cultivate and maintain an adequate provider network. And what that means is that if the people you're serving have dual diagnoses, that part of your responsibility is to cultivate a network of providers who are capable of serving those folks. So it's not going to be adequate to have mental health experts who know nothing about developmental disability. It is not going to be adequate to have DD supports that exclude people with mental health disabilities, right? That's just not going to work because people don't fit neatly into little boxes. We hate little boxes. All right. So this sort of individualized approach is critical, but ultimately the responsibility for making sure that there is a professional who can do the work, that is up to the MCOs. And that is not, I don't say that flippantly. I'm not saying it's easy. I think it is going to require some real innovation because I think we have allowed those gaps to exist and frankly widen for some time. And so I'm really hopeful that we will all work cooperatively with our MCOs, but really in our communities, with our provider communities to deepen the knowledge. Some of it's going to be taking our existing provider community and improving their knowledge and skills. Some of it is going to be perhaps cultivating new providers altogether, new kinds of providers, or encouraging providers to serve, and by encouraging, I mean incentivizing, like with money maybe, providers to serve the people who were having difficulty identifying providers for. It is amazing what people do when you pay them to do it. You pay them adequately and you respect them as professionals. And I really think that we have a long way to go on that, but I think that's one of the places where we can make the biggest impact if we're able to actually build up the capacity of our service system to serve folks who, have the audacity to have more than one set of needs.
Thank you, Corey. Kelly, would you like to add to that?
Yeah, I mean, everything Corey said is wonderful. And I think, we've had a lot of fits starts, some successes, some not, with opportunities to train and create more workforce, people who are comfortable and feel like they have a good skill set to actually support people with mental health and IDD. So part of what we're trying to understand is, and what happened there, right? Did the training not stick? Did we lose that workforce, et cetera? It is really critical. And this is something that's, we're looking at our own services too, right? We're putting out lots of money in crisis. Do we need alternative crisis models for people with IDD, or we just need to make sure that all of our crisis responders are well-trained to support people with IDD? Regardless of whatever the solution is, we need a solution. But I agree. I think, we are recognizing here nationally, the need is great. People with IDD experience a significant amount of trauma just in their everyday life sometimes. Going to school and dealing with communities who aren't always inclusive like they need to be. And so the need is great. And we need to make sure that we're meeting the needs of our citizens here in North Carolina. So everything Corey said, I completely agree with 100%. And one of the things we'll be doing with our block grant, pay attention in the summer, is we'll actually be releasing some funding to make sure that we're building some capacity for mental health supports for people with intellectual and developmental disabilities.
Thank you both. We've had some great discussions and great questions, y'all, today. I really appreciate it. We have time for about one more question, and we will answer the question we received on building and developing a peer support service for parents, guardians, people with IDD. They noted that mental health and substance use have it, and there's a noted need for that for folks with IDD. Kelly, would you like to speak to that?
Yay, yes. And hopefully folks know, there's a couple of things that I want to point out, right? There are some LMEs, right? Some of you are on the call today that have really cool models of peer support using folks with their own IDD lived experience and or family members. We also have some community-based organizations who might be on the call today who are really family members of people with intellectual and developmental disabilities who are helping other family members. So they've started their own organizations organically. So we've got lots of pockets of really wonderful things. What we are doing as we are expanding peer services across the state, we intend to continue to support through additional funding, through, again, also meeting with Medicaid and our managed care plans about the sustainability of those things. But we want to continue to fund families helping families in the IDD community, right? Those are wonderful things, wonderful. They're not traditional treatment services, but they're so vital. families keep families going. And we want to honor that and respect it and acknowledge it. But we also want to make sure, and it is part of our peer conversations, we have a peer advisory group. We are working on standardized peer certifications and specializations, family peers, and also peers, people with IDD. Supporting other folks with IDD is a priority for our peer work as well. So we are right there with you. It's much needed and it's very exciting. Peers helping peers are just remarkable.
Corey, go ahead. I saw you come off mute.
Just another round of applause for peers and peer-led everything. I hope that I hope folks know that we're actually a little behind on this front. You know, like we're not the first people to ever have this idea. It's happening in some places, and we can do this. You know, all of the hard-won knowledge that the folks on this call have from having navigated whatever part in the system you play, that's going to be gold to someone who's at the beginning of their journey, right? So share it, but also let's actually formalize it and create a payment structure for it so that people can feel like that work, which is work, let's be real about it, is valued.
100%.
A beautiful and meaningful note to end today's conversation on. Really appreciate the time everyone has taken to submit really thoughtful questions to today's conversation, and I'll turn it over to LaToya to close this out.
Thank you for joining us today. If we did not get an opportunity to answer your question during the webinar, questions and feedback are welcome at bhidd.helpcenter@dhhs.nc.gov. The recording and presentation slides for today's event will be posting on our community engagement and training webpage. The links are included in the chat box. This concludes our webinar. Thank you for attending.